national briefing webinar. Today we'll be talking about payment reform, and of course something that most of you have probably been very involved with over the last several months, MACRA. More specifically, how MACRA is going to impact primary care. So we're going to hear lots about that today from our CEO and President, Marcy Nielsen. Just a few reminders for everyone and a couple of announcements. So in addition to the webinar that we'll be doing today, those slides, of course, will be up on our website tomorrow, along with a full recording of the presentation. So for those of you who have colleagues who were not able to join the live presentation today, please do send them to our website tomorrow, and they'll be able to get all that information. In addition to the webinar for today, we have lots of other resources on MACRA available on our website currently. So you can go to the PCPCC.org website. You can download our official comments on MACRA, our news release, press release, and other additional links to information that's available out there. Even though the official comment period has now closed, there's still going to be a lot of activity and dialogue about MACRA and their implications moving forward. So I encourage you to go there. If you haven't already, of course, be sure you have on your calendar the 2016 Annual Fall Conference. This year it's November 9th through the 11th, same place, same hotel, Washington, D.C. at the Grand Hyatt. I know many of you have attended our awards dinner in addition to our annual conference in the past. This year is going to be an extra special event. It's always an incredibly inspiring event. Obviously the networking is fantastic. Some of the most prestigious leaders from primary care and healthcare, not just from the DC area but nationally, attend that. But this year is going to be especially important as we're going to be celebrating 10 years of the PCPCC, but even more importantly, we'll be celebrating 10 years of Paul Grundy, who helped get the PCPCC up and started. So talking about not just the work that he's done for the PCPCC over the last 10 years, plus 10 years, but all the great work that he's done in helping to improve primary care. So there's lots of information up on our website about the awards dinner, sponsorship opportunities. We hope all of you and your colleagues and lots of people will come out to help us honor Dr. Grundy at that event, in addition to several other very stellar and worthy awardees. So I'm just going to go now, run through for those of you who've never been on our webinar before. How we roll is we do not take live comments or questions during the webinar, but feel free, or we don't take them voice over the phone, but feel free to chat them into the dashboard. So there's a box for questions. You can submit questions or comments at any time during the webinar. And if we have time at the end, we'll be asking a few of those. I'll be posing those to Marcy at the close of her presentation. So again, our speaker today is Marcy Nielsen, our CEO and President. I think most of you know who Marcy is if you're coming to the PCPCC. Of course, her detailed bio is available up on our website. But with that, Marcy, I'm going to go ahead and turn it over to you.
Terrific. Thank you so much, Amy. And thank you, everyone, for joining us this afternoon. We are all, I think, very much focused on MACRA, and there is so much there. Today's presentation certainly couldn't cover all of the 962-page proposed regulation that Amy just mentioned. The comments were due on Monday evening. So today's presentation is really going to be a focus more on the pieces that most impact primary care from the lens of the PCPCC. And with that, there are really three major things we're going to cover today. What is MACRA? Big picture. Why is it so important in health policy and in advanced primary care? And then what specifically did the PCPCC say in our response letter that we filed on Monday evening, and as Amy pointed out, is available on our website, and I'll be sharing that URL with you as well. So for starters, a lot of this is going to be review, so I'm going to kind of quickly hop through several of these slides. But what is MACRA? Many of us worked on the legislation that was passed a full year ago. It's the Medicare Access and Chip Reauthorization Act. But in the proposed rule, CMS tried to give it a bit of a new name to indicate what the purpose of MACRA is. And so you'll also hear the Quality Payment Program as a title for MACRA. It really does the three things outlined in this slide, and by the way, these slides are terrific resources that CMS is making available, and I'm going to share that URL with you as well. But first and foremost, it repeals the sustainable growth rate. I'm going to talk about that briefly. It aims to streamline the various multiple quality reporting programs that physicians and nurse practitioners and PAs and other professionals are currently using. But it also, and this is the big paradigm shift, it provides incentive payments for participating in what the regulation is calling advanced alternative payment models. And we'll go through this in a bit more detail. The easiest way to think about MACRA is it's really kind of two buckets. This is very, this is oversimplifying a very complicated law and regulation, but think of two buckets. The first is the merit-based incentive payment system, or MIPS, and then the second is this advanced alternative payment model, APMs, and the goal in general is to get providers from MIPS, which is where most providers will begin, and get them on a pathway to become advanced alternative payment models. And you'll see why in a moment. CMS points out that they recognize that this is a first step to a fresh start regarding how we pay clinicians in Medicare. They are listening and they are helping, and the materials that they are providing are really stellar. I'm going to share some of those with you today. They do see this as a way to build a better, smarter Medicare program to pay for what's working in Medicare that is sustainable, and the health information aspect of this, recognizing there's much work to be done there, and the PCPCC has a few comments in that regard. If you wanted to think about MACRA in one easy slide, this would be the slide that gets you sort of closest. There's nothing easy about this slide, but as I mentioned, if you think about the two buckets, MIPS and APMs, you'll find them in the far left-hand corner. And of course, across the top, you'll see what we need to be doing over the course of time, from 2016 to 2022. You'll see in the middle section there under MIPS, the numbers 4%, 5%, 7%. I'll be talking about that more in a moment. These are opportunities for those providers that stay in the merit-based incentive payment system. Those are the opportunities for providers to both increase and or receive negative adjustments on their underlying fee-for-service payment. And then in the next row, under alternative payment models, you see the 5%, 5%, 5%. This is the advanced APMs, a bonus of 5%, bonus stopping after 2024, but a big incentive to participating, because not only do you receive the 5% bonus, but you get out from under having to report all of the things you'll report in MIPS. And then the very bottom column, in terms of additional funding, you'll see some dollars set aside for specific activities. First, for measure development, $15 million, $20 million every year for technical assistance for small practices, and then at the final arrow, up to $500 million beginning in 2019 for those providers who provide exceptional performance under MIPS, and I'll say more about that in a moment as well. When you think about the way to explain this program, I really encourage you to stop and look at the materials that CMS has developed. And I've gone so far as to actually include this particular video because I think it does a fabulous job of explaining quickly what this program is about. And I am going to go ahead and play it for you. I'm not sure if you can hear it. I can't hear it. And I wonder if I need to turn up the volume. It's got beautiful drawing. Jacinta, can you hear this?
I can hear it.
And I'm just going to listen.
Instead, our system pays for tests, treatments, and procedures. Saw 30 patients in a day? Check. Did a biopsy? Check. Read an x-ray? Check. Not surprisingly, this has led to more services and higher costs, and it often leaves doctors and patients unsatisfied. Over the years, different programs have tried to make things better, but change was sporadic and fragmented. We have made progress, like helping the vast majority of doctors adopt electronic health records. But some of the requirements were too complicated or complex, and the fundamental goals got lost. Many doctors were frustrated, and some couldn't or didn't want to take part. To help fix this, Congress recently passed a bipartisan bill, supported by doctors and medical groups, to change how we pay for care. This new effort is called the Medicare Quality Payment Program. Instead of payments that encourage assembly line style of care, this program helps doctors focus on quality and the one thing that matters most, whether patients are getting healthier. Here's how. First, it replaces our patchwork collection of incentive and penalty programs with a single one. And though we will still pay for services, every doctor will have the opportunity to be paid more for better care and investments that support patients, like creating a helpline or having nurses follow up at home. And for doctors who want to go further, there's a second option that's even more flexible. They can decide to be part of new organizations that get paid primarily for keeping people healthy. For example, they could be part of a health home, where a team of doctors work together to meet a patient's needs. On this track, doctors can help patients understand prevention and wellness. They can try innovative approaches like telehealth or nutrition classes, and they can focus on keeping people healthy. We are working with doctors, insurers, health organizations, and patients to make sure we find the path that works, one that's simple to use, pays for better care, and keeps important programs like Medicare sustainable. These kind of smarter payments give doctors more freedom to practice medicine the best way they know how. They take people off the assembly line and put them in the center of their care, and they are key to making our system work better for everyone. To find out more about other efforts like this, go to hhs.gov/delivery system reform. Better, smarter, healthier. This is the future of healthcare in America.
Thank you very much, Jacinta, and hope that the folks who are tuned into this webinar found this as useful as I did. You can find that video along with other terrific resources that CMS has on the URL listed here. In addition, I would certainly want to give credit to CMS for the many, many different slides that they have drilling down to very specific aspects of MACRA. And I have borrowed quite a bit in this presentation. There are even widgets, which I don't know what those are, but I was impressed that they had them. So why is MACRA so important to primary care? And I think what happens in Washington is we just think that that's a given, but it's actually not a given. I think for primary care practices who are trying to take care of patients and be focused on keeping them healthy, what happens in Washington often feels so disconnected from what they're doing. So I think it's important for us to step back for a minute and remind ourselves why MACRA in particular is so important to primary care. And I think for starters, remembering that this particular slide and this particular quote, each system is perfectly designed to achieve the results it gets. There is a reason that primary care practices feel that they are on a gerbil wheel, unable to keep up with all of the things that their patients need. And it is because we are stuck in a fee-for-service system. You'll see listed there in the first column, in a fee-for-service system that pushes volume-driven care and undermines our ability to really give patients all of the things that they need to get healthy and stay healthy, things that fee-for-service frankly just doesn't pay for. We've evolved over time. We learned a lot through the DRG system, diagnosis resource groups, diagnosis-related groups, excuse me, and that's helped us, certainly in the hospital world, think about how prospectively we might look at at a healthcare episode or diagnosis and treatment and do a better job of anticipating what a patient needs and what the appropriate costs are. But in a world in which we've got lots of different ways in which the siloed, fragmented nature of healthcare undermines our bigger goal of healthy patients, really accountable care, value-based care, this new opportunity for advanced APMs gives us the opportunity to align all of the incentives so that we're not driving patient volume in order to drive clinician reimbursement. We're not driving length of stay and pushing that up in order to increase reimbursement. And we're not doing too many tests and really using healthcare in a way that is wasteful. In fact, as we align all of the incentives in our healthcare system, the goal should be that we can decrease the number of patients we see because we're keeping them healthier, decrease the length of stay, decrease the kinds of tests that we are proposing that they have, because we have built into the system at a system level alignment across what the patient first and foremost needs. That pressure, that opportunity, that challenge comes back to primary care. And for those of you who have heard me speak in the past, I say this with all of the feminist spirit that I embody, primary care is very much the it girl of public policy right now. A recognition that the 30 years of research that Barbara Starfield and many, many, many other colleagues have embarked upon tells us that primary care in many ways is the answer to the fragmentation we have in our healthcare system. And so we are relying on primary care to help us deliver better healthcare, but we do not pay primary care in a way that allows us to do that in a sustainable way. And so the triple aim that we often hear spoken about, we heard about it in the video, is certainly a goal: better patient experience, lower per capita healthcare costs, improved quality. But we're putting an awful lot on the backs of primary care clinicians who are being asked to do more and be more and take care of massive needs of their patient in ways that are entirely consistent with what they believe and what they're trained in. But we're doing that before payment reform has happened. And so what we've got is a disconnect between primary care clinicians and practices and teams that want to do this work, but without the resources to do it effectively. And accordingly, they are getting burned out, and they are getting angry, and they are getting tired. And so we've got to elevate the joy in practice, the satisfaction with offering this kind of care. We need to elevate that in a way that ensures that as we make this huge transition to value-based payment, to alternative payment models, we keep those clinicians in the game, happy as they possibly can be in a time of great change. And so here at the PCPCC, we are trying to elevate that aspect of our work. And you'll note that this comes into play in our MACRA comments. We've got many challenges in primary care. Many folks are well aware of these. We certainly have Americans who lack adequate access for a whole host of reasons, some dealing with cost, some dealing with workforce, some dealing with health disparities. 60 million Americans lacking access to primary care. And you can see from this terrific slide from the Primary Care Project, there are lots of figures here that are discouraging. I hope by the end of this presentation we'll be offering you some encouraging information. But important to note, 50 years ago, half of the doctors in the United States were practicing primary care. And today we've got fewer than a third that do. But if we had those primary care clinicians offering all of the services in a traditional model of care delivery, all of the services that their patients need, they'd be practicing 21.7 hours a day. And so something's got to give. We know that most of the healthcare dollar today, in one way, shape, or form, is spent on treating a chronic disease, a person with chronic disease, about 75 cents on the dollar. And so many of the aspects of treating chronic illness come back to paying attention to behavioral health issues, mental health issues, integration of those kinds of services. And yet we've got 128 out of 750 institutions that train physicians offering no primary care graduates at all. And certainly the cost of training a medical resident is incredibly expensive. It is borne by Medicare, and so it is absolutely related to Medicare payment reform, and that's about $500,000 a resident. In addition, if those challenges weren't enough, what we've done in the primary care movement is really try to elevate in a way that payers can understand, health plans can understand, even patients can understand when primary care is delivered at its best. It should very much mirror this notion of a patient-centered medical home. But over the course of the last decade, the term patient-centered medical home has lost sort of its meaning. In some ways, we very much see it as a process by which we can certify that a practice has done specific things and that practice will be reimbursed more highly. But in lots of places, there are no opportunities for increased reimbursement, and the whole concept has a different meaning based on who's approaching it. So is patient-centered medical home really a good housekeeping seal of approval? Because that's what we anticipate the public views PCMH as. But if you are a practice, and this work is certainly arduous, it takes a long time, anywhere between 18 months and really 3 years, depending on the practice itself and whether it starts with the advantages of having an electronic health record already integrated into the workflow. Those practices may view PCMH more as a quality improvement process versus really thinking about it as a good housekeeping seal. And then from the perspective of payers and employers, it's a means by which an accrediting organization can take a look at that practice and say, yes, this practice is deserving of additional resources because they are offering this kind of high-performing primary care that we think is consistent with the triple aim, which we believe should be the quadruple aim. But for the purposes of today's conversation and for the purposes of how it was defined in MACRA, PCMH is actually thought of as a payment model. And so we wanted to acknowledge that. But we also wanted to be certain that folks recognized it can be viewed as an ideal process, and I took out a slide here, as an ideal of what a medical practice should be, a primary care practice, versus just being a process-driven. This is just one example of the various things that a primary care practice would have to do to get accreditation. This is actually a cheat sheet to become a specialty practice, but the same sorts of standards apply. And here's the slide I was thinking of. Viewing PCMH really as a certification versus as an ideal of practice transformation, and the North Star, this aspirational guide, two very different ways to think of PCMH, and both in some ways are embodied in MACRA. At the end of the day, where the PCPCC comes down is really what you see here. What's most important to patients, families, caregivers, and consumers? I think PCMH is, and this notion of a high-performing primary care practice, patients, families, caregivers, and consumers just want to know that primary care practices that deliver this kind of care are fairly reimbursed and are able to focus on them as patients first and foremost. There are so many measures in the current healthcare reimbursement system that make very little sense to practices. They're redundant, they're not tied to outcomes, they're different across payers, even though they're trying to measure the same things. And a fair amount of work has been done in what is sometimes referred to as the measurement industrial complex. And this brings us to the MACRA terror. As I go around the country and talk to folks, what you quickly recognize is that MACRA is not seen as an opportunity to really lift up practices and improve the kind of care that they can offer because it's fairly reimbursing them. But in fact, it's one more thing on top of many others that practices are expected to do. And so it's really our responsibility, all of us, to break down the MACRA terror, to turn it into understandable information, and that's what I think we have an opportunity to start doing today. And as we look forward to November's final rule, when hopefully we will have improved the proposed rule by making it a bit more simple, a bit more common sense, we'll be able, all of us together, to demystify the MACRA terror, explain it for what it is, and get all providers who are interested in offering this kind of care to engage, understand, and start down the path. And so let's remember where we started. I was working for my United States Senator in 1997 and remember well when we passed the sustainable growth rate. At the time, passage of that particular law was really meant to control the costs of Medicare. And yet what we found is we had artificially put on top of the Medicare system a formula that if overall physician costs were more than Medicare targeted expenditures, we expected pay cuts to happen across the board. They did not happen. Over the course of 17, 18 years, there were numerous attempts for pay cuts, and the physician organizations were always able to come in and point out how devastating that would be to care. And so what happened is every year there would be what we called a doc fix that would be temporary to avert cuts. In 2015, had we not come in and done that doc fix, it would have meant a 21% pay cut in payments to clinicians. And so the goal of MACRA politically at the outset was to address the sustainable growth rate, which wasn't working, but then to use this as an opportunity to really improve overall how we would pay clinicians in Medicare. And so this is where we landed. We passed legislation a little over a year ago. We were fortunate that we had a bipartisan majority in both houses interested in really helping push what we believe to be paradigm-shifting opportunities in better paying for Medicare then impacting in many, many cases what the private sector does. The regulation, as I mentioned, 962 pages, comments due on Monday, and the PCPCC, much like many, many other organizations across the country, weighed in. But the perspective of the PCPCC is different in that we don't just represent a single kind of constituency, but we try to represent the Venn diagram, if you will, and the little purple people in the middle, who in fact represent a unified view of what the public expects from its health system, what the payers expect from their healthcare system, and what healthcare providers expect from their healthcare system. And the role then of the collaborative is really to convene, to get folks together, to try to unify around those ideas, to then advocate those ideas that folks think are important, and to disseminate what we've learned. And so what we unify around is really better investment in team-based, patient-centered primary care. And our regulatory comments, our comments on the regulatory proposal really are centered in that space. Now, we started out recognizing that there was much in the reg that we liked. That makes a lot of sense. It was a statute that we were proud to see Congress pass and the President sign. The role of patient-centered medical homes in that bill is important, and I'm going to come back to that. And we were pleased to see many things in the proposed reg that supports that. Around quality measurement and reporting, some definite improvements that we'll speak to, one of which focuses on how patients report on how they're doing, and not having everything driven by the clinician, really asking patients as partners to tell the clinician and the care team what they're feeling, recognizing that true partnership requires input from everyone. We were certainly thrilled to see that the Comprehensive Primary Care Plus program that was announced this spring was highlighted as that advanced alternative payment model that I spoke to earlier, that really is the paradigm shift, and we'll come back to that. And we were very excited to see within the MIPS clinical practice improvement activities a new focus on achieving health equity and a new focus on integration of behavioral and mental health. It's not that we haven't had folks focus on these issues for decades. It's that we haven't been building them in an overt way to how clinicians were paid. And so that's the difference that we think is important, and we think we can even improve on in the proposed reg. And then finally, as I'll mention later, we were not thrilled to see only 6 kinds of models, I'm going to share them with you here in a moment, that were recognized as advanced APMs, only one of which was a primary care model. That's this Comprehensive Primary Care Plus. But built into the statute was a way for a host of technical payment experts to continue offering up advice to CMS about who else should have an opportunity to be viewed as an advanced APM. And so we appreciate that CMS has this group of experts that are going to help them, and we've made some suggestions, not the least of which is a new idea asking CMS to work with the PTAC to focus on how much of payment in Medicare is actually going to primary care clinicians. Too often what we've seen in many ACO models is payment that comes in very much in a comprehensive fashion, giving flexibility to clinicians, but that never arrives at the doorstep of the primary care practice who continues to get paid in a fee-for-service kind of format. And so we want CMS working with PTAC to think about how we measure whether this paradigm shift is actually occurring. I'm not going to spend a whole lot more time on what we liked in the reg. I'm going to spend more time based on what we feel like needs to be improved upon. And I'm not going to read these to you now because I'm going to go into each one in more detail. But that requires a little bit of background on what the actual reg proposed. So if you think, again, of MACRA as being 2 buckets, the merit-based incentive payment system, which is really fee-for-service, plus an up or down adjustment over time, and then this advanced alternative payment model, which is the gold standard by which practices are given flexibility as well as bonus payments through 2024. I'm now going to give you a little bit of background before I offer up the PCPCC's recommended improvements. First, acknowledging right from the get-go that most practitioners are going to start in MIPS. You're going to start in the fee-for-service setting, and this is a nice slide to describe, and I'm not going to get into all the technicalities. You are subject to MIPS, in other words, subject to the measurement requirements along these lines. You're not in an alternative payment model. You are not, or you are in an alternative payment model but a non-advanced payment model, or you're part of the advanced payment model but you yourself are not a qualified clinician. Again, don't want to get into a ton of qualified practitioner, into a ton of detail here, just trying to give you some background as to what the various definitions mean. MIPS is a new opportunity, even within fee-for-service, because what MIPS is trying to do is streamline 3 completely independent programs that were very much a source of frustration to clinicians in terms of administrative hassle and burden. And then to add a 4th component listed here, which is this clinical practice improvement activity, and I'm going to speak to that more in a moment. The folks who will participate in MIPS, as you can see listed in years 1 and 2, physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. But in years 3 and beyond, there will be opportunity for a whole host of additional clinicians to be able to participate in MIPS. There are folks who will not have to or be allowed to participate in MIPS. If you are a clinician who is in your 1st year of participating in Medicare Part B, you do not have to participate in MIPS. If you don't take care of enough patients, you don't have to participate in MIPS, and CMS defines for us what that is. Or you are a participant in an advanced alternative payment model, you are not subject then to the requirements of MIPS. And just to note, this doesn't apply to hospitals or facilities. Those performance categories, as mentioned earlier, quality, resource use, clinical practice improvement activities, this is the new category, and then advancing care information. And this is really meant to replace meaningful use from the HITECH Act. Those components then roll up into a single score, the composite performance score. And you can see here which elements of MIPS are counted with what weight. So quality is 50% of your score, cost is 10%, these clinical practice improvement activities 15%, and then advancing care information, again, replacing meaningful use, is 25%. Now, drilling down even further, and this is important because it relates back to some of the PCPCC comments. Under quality, you'll see clinicians get to choose from 6 measures to report to CMS, and various different ways in which this information can be reported back to CMS. Next, under advancing care information, again, this is to replace meaningful use, clinicians will report key measures of patient engagement and information exchange. I'm going to talk about that more in a moment. The clinical practice improvement activity is one where we would want to underscore clinicians participating in medical homes, in other words, certified medical homes, earn full credit in this category right from the get-go. You get 60 points, which is 15% of your score. If you're participating in an advanced APM, whether it's in a medical, outside of a medical home, you get half the credit. And then cost measures are sort of obvious, although we've got some issues with the way in which those measures are going to be currently calculated as part of the proposed rule. 10%, all of these, the average score, the clinicians don't have to report this because CMS will have this information. Where all this is important is that it impacts what you will be reimbursed over time. And you'll see you have an opportunity to earn a 4%, 5%, 7%, 9% bonus over time beginning in 2019, or you will have a downward adjustment based on your score. That score is that you will be judged by this composite performance score. You will be compared to a threshold, and that threshold right now is tied to the entity in which you are connected to, but it compares all clinicians, and that's something that I think lots of folks are hoping CMS alters as they finalize their rule. Here's what's alarming. We start in 2017, January, just 6 months away, is when the first performance period begins. So a full year performance, everyone will be assessed during 2017, and what you do in 2017 then will impact what you are paid in 2019. That's a full 2-year difference from January 2017 to 2019. And what you'll find is that then this 2017 performance period and payment year is far more disconnected than I think clinicians anticipate. There's one area that I hope CMS changes in their final rule. But you'll also see over time this MIPS adjustment that goes up beginning in 2019, the bonus also starting in 2019. If you're using the performance year of 2017, that is an awfully quick turnaround. 6 months from now, the regulation won't even be finalized until November. And so one of the first recommendations that the PCPCC is making, along with many others, is that we think the timeline is too aggressive, especially for solo and small practices that may have a lot of work to do before they actually are in a position to submit their measures. So we are urging CMS to start the initial period of assessment no earlier than July 1 of 2017, even better if it's 2018, but we just feel like there is far too much work for practices to do to get ready. The next I mentioned under the CPIA, the Clinical Practice Improvement Activities, that medical homes receive the full 60 points, 15% of their total composite score. But right now CMS is only suggesting that 4 nationally recognized medical home accreditors be allowed to determine who would receive that particular accreditation that then Medicare recognizes. We feel like that we certainly would support all 4 of them being included, but we also think it would be very short-sighted to not use the number of fantastic state-based programs or regional programs, and so we are recommending, as are many others, that we utilize accreditation programs that have a demonstrated track record of support by other non-Medicare payers, state Medicaid programs, employers, or others in a region or state. An example would be Blue Cross Blue Shield of Michigan. Lots of peer-reviewed data that suggests that their program is working, the accreditation process is working, and we feel like they should not have to jump through additional hoops in order to participate as an accreditor. But we did some terrific work with the accreditation organizations themselves, but a broad multi-stakeholder group to really look at what we need to be doing to improve accreditation in general. Those recommendations are on our website. We're grateful to the folks who invested many, many hours in making those recommendations, and we think CMS should consider them as they look to decide who should get to participate as an accreditor. We also are concerned that despite the intent of merging these 3 old programs and then the 4th CPIA program, we are building off of legacy programs, particularly with the Advancing Care Information performance category, and there's disparity in how primary care and specialty specialists are asked to report based on the kinds of measures that are available. There was a several-month process that another multi-stakeholder group, the PCPCC, was not involved in this, but the Core Quality Measures Collaborative, which CMS was involved in, that AHIP was involved in, and many others. It would be important that we have a single, parsimonious, unified set of quality measures that all providers were expected to participate in. And this was not included in the proposed reg, and we think it should be. We think, as I mentioned earlier, a number of terrific improvements, but under the Advancing Care Information section to replace meaningful use, still a host of issues. Some real concern in the provider community that using EHRs isn't getting easier, and EHRs still so very much tied to billing instead of a clinician's workflow, not tied to improvements in patient outcomes, and interoperability still a huge issue. And so we have many organizations, to include the PCPCC, asking CMS to go back and take another look at the Advancing Care Information section. And then this issue of solo and small practices is coming up over and over and over again, and rightly so. For small practices, of which there are many, half of all family physicians today are in small or solo practices, so five clinicians or less. What we know to do all of the work to be able to become a patient-centered medical home, certainly an advanced APM, is hugely time-consuming, often expensive, and we need then to give those solo and small practices some special consideration in the proposed rule. CMS did this in several places, certainly acknowledged the special challenges that they have, but we think that they could do more, and particularly around the creation of virtual groups, which you see mentioned here in the second bullet. MACRA, the statute, required CMS to develop virtual groups so that solo and small practices don't have to join an ACO or other kind of IPA in order to participate in value-based payment through Medicare, and yet CMS, based on all the constant work that they are engaged in, was unable to include them in the proposed reg. They just didn't feel like they could put that program together in a way that they were confident around, and so recognizing that that's an unfortunate challenge, until there are virtual groups that solo and small practices can participate in, we think that they need to CMS needs to create a safe harbor exemption so that a solo or small practice can enroll in MIPS, can participate, but will not be subject to a negative payment update, because they won't have at their disposal the opportunity to use a virtual group that they would essentially be able to report as a group. Until that opportunity is availed to them, they shouldn't get a pay cut. And you'll, I hope, see some movement at CMS on this very important topic for solo and small practices. And then the final section under MIPS really gets back to beneficiary engagement, and something that we have been focused on a lot as part of the Support and Alignment Network grant, and really since in some ways the inception of the PCPCC. How do we make primary care patient-centered? What does beneficiary engagement mean? Too often it still means engaging patients at the point of care instead of thinking about ways we can engage with patients as part of quality improvement. And so we are suggesting that all 6 of the clinical practice improvement activity subcategories have opportunities to partner with beneficiaries. And we wanted to highlight three that we think are particularly important, although there are many. But integrating social determinants of health and promoting social and community involvement is certainly one. Patient and family advisory councils, key governance decision-making bodies, but there are two pieces of CPIA, the health equity and integrating behavioral and mental health that we would also want to highlight. So on to alternative payment models, and I promise I am almost done and know we're coming to the top of the hour. Really, alternative payment models are the new approach to paying for medical care through Medicare. And as based on the MACRA statute, how you become an APM is you are an innovation center model. So Section 1115A, you are a Medicare Shared Savings Program, an MSSP. You are a demonstration under the Healthcare Quality Demonstration Program, or a demonstration required by federal law. But remember, an APM isn't the same thing as an advanced APM. Advanced APMs have to meet certain criteria in the proposed rule outlined here. They've got to be using certified electronic health record technology. They've got to basically be offering quality measures and getting paid based on quality measures. They don't have to submit MIPS. They don't have to provide those measures to CMS, but they need to be providing some measures that are comparable to those. And then finally, and this is a very important one, the APM is either required an APM entity to bear more than nominal financial risk for monetary losses, often referred to as downside risk, or, and this was something that you might imagine the PCPCC cared a great deal about, or they are a medical home model expanded under CMMI. And so the medical home model that could be expanded under CMMI is really the comprehensive primary care program. Now, CMS wants to remind us, MACRA doesn't change how any particular APM functions or rewards value. It just creates extra incentives. And so the folks who want to participate, they want to become a qualifying APM participant, qualifying being important. You can see here the advantages. You're excluded from MIPS, and you receive this 5% lump sum bonus through 2024. To become a qualified participant, you've got to be getting payments or have a certain percentage of your patients or payments that come through this advanced APM. Now, that does allow for Medicaid or private payers that are paying you as an alternative payment model. They can actually help you to become a qualified participant in Medicare. Again, don't want to go through all of these details given the time, but also given the complexity and the possibility that we hope some of this will change. But starting in 2021, some arrangements with non-Medicare payers can count to becoming a qualified participant in Medicare. Now, medical homes, they point out in the proposed rule, have a unique financial risk other than other advanced APMs because medical homes are largely primary care practices who can't take on the same kind of financial risk that a big health system might be able to. And so they outline what they define as a medical home model. This slide in particular is focused on Medicaid medical home, but you've got to be part of a primary care practice. You've got to impanel your patients, and then you need to do at least 4 of the following things consistent with a patient-centered medical home model of care. And here you can see this idea of nominal, the nominal amount standard relative to the amount of risk you are expected to take on. And if you are a medical home that is smaller you're part of an organization with 50 eligible clinicians or less, you have a different nominal amount standard than other advanced APMs. But we've got some concerns about this proposal. This is sort of an interesting slide, and it's my final slide from CMS. How overall is this program going to affect you? Well, first things first, are you in an advanced APM? That's the most advantageous? Yep, you're in one. Do I have enough patients or payments through this advanced APM? Yes, you do. You don't have to participate in MIPS. You get this 5% bonus that begins in 2019, ends in 2024, and then you are eligible for higher fee schedule updates as well as other alternative payment model specific rewards. But lots of folks aren't going to be in an advanced APM. And so here you follow this flow chart. You can still earn increased reimbursement if you've got favorable scores. And you can see here who is not required to participate in MIPS or as an APM. The bottom line is the little piggy. There will be financial incentives for participating in an APM even if you don't become a qualified participant. And now we are almost at the end of the presentation, and this is a pretty important recommendation that we made to CMS, and that is we really think that the advanced alternative payment models are too narrow in the proposed rule. We believe that medical homes actually were intended to be advanced APMs, and so we support multiple ways to become an advanced APM, and together with lots of the other primary care physician organizations, we think we ought to take a look at CPC, expedite that process so that the Medicare actuaries look at the program, determine whether or not it improved quality without increasing cost. So that would be step one. The step two pathway, assuming we can do all of this at the same time, we think we ought to allow a deeming program that enables those high-performing practices that already are doing the same kind of high-performing primary care functions as CPC practices, and that they ought to be deemed as getting to be a participant in an advanced APM. And then finally, we question whether there ought to be any kind of financial standard for nominal risk at all for medical homes. That was something that was not included in the statute. It's something that CMS added. We know they added it as a recognition that those particular small entities, 50 clinicians or less, should not have to live up to all the same standards as big organizations. But we would submit Congress never intended to have medical homes live up to any sort of downside risk. And with that, you can find more details, not as detailed as some of our colleagues, for example, at the American Academy of Family Physicians, or ACP, who had comments in the hundreds. We've got a 5-page summary of our recommendations that we'd be happy to have you share. And my final thought, and this really relates back to the video that you saw from CMS, as much as it feels like we are trying to break down the practice of primary care into bits and pieces and pay accordingly. This is not that kind of technical proposition, this being good primary care given in partnership with patients and families. Clinicians are not line workers who produce bits of healthcare, and clinics aren't factories. So at the end of the day, whatever these proposed regs turn into, they need to elevate that caring, trusted healing relationship between clinicians and patients, and get the administrative work off to the side so that the so that the patient work is at the forefront. And with that, Amy, I know that we are right at the end of the hour. I feared as much. I suspect we maybe had some questions, but perhaps they are questions that we may be able to answer offline.
Yeah, I've been answering most of the questions as you've been going through your presentation. So we'll certainly be talking lots more about MACRA, all of its implications over the many months and certainly even years ahead. So there will be lots more to come on all of this as we move forward into these new payment models. So I want to thank everyone for attending today. Again, this webinar will be available in its full recording along with a copy of the slides up on the PCPCC.org website tomorrow afternoon. Thank you, everyone. Have a great afternoon.